electrons cross from each hemisphere. So basically, whatever happens on the right is happening on the left side of the body. Dysarthria. Basically, they'll understand what you say, but they can't get the words out. Aphasia, left side of the brain, the inability to produce or understand speech. So they can't understand what you're saying. They'll look, question, what do you, stuff like that. And then, of course, paralysis of the right side of the body is in the left hemisphere of the brain.
Think about aphasia as like, if I come up to you and I ask you, how are you doing today? And you say, the dog is fine. Like, understanding speech is very difficult, right? Dysarthria is, very, they're hard, hard to understand. Do you guys know any other medical conditions where it causes them, it's really hard to understand how they talk? I had a patient once where I couldn't understand almost anything he said. I made him repeat himself maybe 2-3 times. Anybody know? No? Cerebral palsy. It's the one that has, like, really, really, really hard to understand talk sometimes. And you gotta really, like, kind of lean in and listen to him, like, really, really carefully. Especially it's really hard in the back of a truck when you hit a bump and everything's moving around. Monitor's making noise. Just everything with speech is very important.
This is the Cincinnati Stroke Scale. It is the easiest to follow. It's FAST as the acronym. Basically, facial droop. Ask them to smile. See if one side is farther up than the other. One side would be either lower or kind of off to the side. It wouldn't go up. Arm drift. Ask them to hold their arms up or hold them up for them, and ask them to hold them there. Let go. They keep them up.
Normal is just one falls.
Yeah, one falls lower than the other or something like that.
And they can't keep it up there. Normally it's, you can keep your arms up for, if you guys did it, how long could you keep your arms up like that? Pretty long time, right? Person with a stroke, maybe not even 2 seconds, or maybe not even at all.
And
right?
it could be hard to figure that out with geriatric patients. Basically, sometimes they're just too weak to even do stuff like that. So it's kind of a hit and miss type deal. But then you have speech. Can't teach an old dog new tricks. That's what we use. They can't say it. It'll be really hard for them to say it. It'll be slurred, like can't teach, stuff like that. It'll be very hard to say stuff like that. And then time. Always got to figure out the time, because at a certain point, even if we take them to a hospital, they'll turn them away. Certain places will take them in, obviously. It's a money business for that, but people will take them in for experimental treatment, basically. Always ask. Big thing. Always ask for the time. Risk factors for it. Non-modifiable risks. You can't change it. You've got the race. As you know, some African Americans have higher blood pressure, which can cause strokes.
Also, sorry.
Go ahead.
Does anybody know what blood cell disease only African Americans can have?
Sickle cell.
Sickle cell.
That can also cause it.
Okay. Sickle cell.
That can cause it. That's very high clot material right there.
Mm-hmm.
Then you've got age. This is a rough age. I think this was from 2008. I think it's gone up now. It's a very wide range now. Now, as low as 25, I'm definite because I did put that in there. 25 is now the age for possible strokes. You can have it at any time.
any age, but that's the general range. Obviously, a 10-year-old having a stroke is extremely rare. Can it happen? Yes. But the general range is 25 to 50. And it's just such a wide range that it can happen to anybody. Again, 1 in 18.
Sex can also change it. A lot of this is based on high blood pressure. I think it was males that have the higher blood pressure than females. So males are more at risk of getting strokes. Heredity, if you have a history of strokes, it can happen. And then we have our rash modifiable strokes, modifiable risk of strokes, which is diet and exercise. Don't just sit around.
I mean, how many times have you guys heard that for medical issues? That's the biggest thing you can do, is diet and exercise. Eating right, and at least working out. Just a little. Really jogging down your road.
All right, this is our scenario. We, what we go through in our mind or say out loud during a patient when we go get them. Basically, we'll go, this is our beginning before we even get to the scene. We will basically, safety, do we have the necessary precautions for them? Gloves, gown, face wear, stuff like that.
Fire, police.
Fire, police. Well, that's our additional resources, which we like to take granted for.
Sometimes there are safety nets.
Number of patients. How many are there? 1, 2, 7, 8. Depends on the amount of ambulances or help we need.
Bless you.
Additional resources goes along with our paramedic or firemen or police. And then we have consider C-spine. Nowadays, they're starting to go away from C-spine precautions, at least with Charleston, especially for backboarding patients. If they don't have back pain and they're able to ambulate, they don't put them on a backboard anymore. That's just with Charleston for now. They've done some studies which have shown that it's really not needed, and it can cause more damage than it should. C-spine is not very far from it. We still C-spine everybody, C-collar everybody, no matter what. If it's just they fell 2 feet or 30, we still do it.
Anybody seen a backboard that we use? It's like, it's literally, imagine a surfboard. It's that rigid, and it's a little kind of indented up to your spine to keep it straight. It's not, we've laid on it. We've been strapped to it.
It sucks.
It's not fun. And you know, on our registry says we have to pad it sometimes if we want to, and it's literally an option if we want to pad it for our patient. I personally have only backboarded one person. I mentioned it to the paramedic, and she's like, no, why? Why do you need to do that? It's going to move, you know, it's going to shift them, and it's not good. It's like, I mean, have you laid on that thing? It's not fun.
And then mechanism of injury or nature of illness. Nature of illness would be the call. Basically, it's for any medical reason. Stroke, people with just hypertension, people just shaking. Mechanism of injury is for trauma, more basically car crashes, accidents, falls, stuff like that.
To add on mechanism of injury or nature of illness, dispatch over the radio, I can tell you, it always sounds worse than it is. Here's an example on maybe my second ride along as a basic. Got a call over the radio. It was 7 in the morning. A patient was a burn patient, and we're like, okay. We get there, it's doctor's office. We're like, it's a little weird, burn patient for in a doctor's office. Who's setting lighters in there? So we go in. She literally zapped her finger on a printer, and had a little tiny singe mark. And we're like, okay. Took her, transported her to the hospital. I mean, there was, I mean, it always sounds worse over dispatch.
Always. But our scenario will start out as we're dispatched to a 65-year-old female complaining of general discomfort, which is a thing apparently. It's basically they just don't feel well. They want to go somewhere. That's it. But don't let that get you, because we do get calls and we underestimate it, where general discomfort is a knife in the chest.
Yeah. And
So,
and that goes back to dispatch.
we arrive on scene. Patient is in her chair holding her head with both hands in the tripod position. Does anybody know what the tripod position is?
No. Basically, make a tripod. Head down.
Then we go on to our actual assessment. Our general impression, patients in the tripod position. Possible head injury or just head pain. Then we look for life threats. None appear. Bleeding airway compromised. She seems to have problems breathing. But that's what we would look for. Bleeding, any type of bleeding, we would stop first. Broken arms isn't a life threat, unless it's protruding and causing massive hemorrhaging.
Do you guys know why some people might be in the tripod position, minus head pain, maybe? Why you might be bent over like that? Looking more for
It
like,
could be abdominal pain.
could be. That's buckling over, kinda. You're on the right track. When you run and you're, exerting yourself, like if you're running a mile for school or something, for gym, I don't know what you guys do. But usually you're like this.
That's also the tripod position too.
Because trying to breathe more, right?
Letting
Gravity's pushing
gravity
down.
take your intercostals
Mhm.
helps you breathe a lot easier. Kind of harms your diaphragm though when you bend over like that. It doesn't contract as hard. That's why whenever you hear a coach say, "Put your hands on your head," it opens up your chest, lets your lungs expand wider. Then we go on to our level of consciousness. We use the acronym AFPU. Are they alert, verbal, responsive to pain, or unresponsive at all? Basically alert. Hi, how are you doing? I'm doing good. Verbal, you'll talk to them and they'll say something back that doesn't exactly make sense, or something along the lines of that.
Basically, talk louder.
Um,
Yell at 'em.
Responsive to pain. They're on the ground, eyes closed. What we're taught to do is a sternal rub.
You just basically rub on your sternum. It's very uncomfortable.
Yes. Any type of pain, pinch them. I wouldn't slap them.
You know what? I don't do it, but I've seen some paramedics go up to you, and if they think you're like, maybe they're asleep, instead of doing sternal rub or pinching, they'll like tap your eyeball. They'll come up and go, and then you'll wake up because it's very annoying. We had a patient that was, supposedly it was a seizure, but we came up and you could see through the store window she was sitting up, and then when we got there she was laying down. So the paramedic came over and he was like, tapped her right in the eye, and she like kind of ignored it and did it again, and she like swatted his hands away and then woke up. It's very annoying. You're not going to just sit there and ignore your eyeball being touched.
After we figure that out, our patient is alert. We move on to our ABCs, which is another acronym. We love acronyms, by the way, in the EMS business. Airway, breathing, circulation. Airway, basically, are they spontaneously patent? Is their throat clear? No obstructions? If so, we move on to breathing. Breathing, we'll check their rate, rhythm, quality.
In the attendance book?
Yeah, please. I'm sorry to disrupt class.
No,
No, you're fine. You go ahead.
Oop, I pulled something out there.
We're here for, I think, 2 hours.
I think this.
Actually, that's what I need right there. Yeah, it's right there.
Okay.
Okay.
I apologize for that.
No, you're fine.
There was two of them here. Do you need both of them or?
While